If we look at the tendons, flexor tendon injuries are more common than extensor, and somehow their repairs can yield better results if you identify the zone and treat them accordingly. Coming from proximal to distal, zone 5 of a flexor tendon is in the forearm. Zone 4 is in carpal tunnel. Zone 3 is lumbricals. Zone 2, the area of pulleys or FDS, is also called as a no man's land because there are poor surgical results in this zone. And zone 1 is a zone of FDP, flexor digitorum profundus. So what is the no man's land? Zone 2, FDS, poor surgical results. If you look at the spine sagittal sections on MRI, you will see that there is a vertebra, a disc, vertebra, disc, vertebra, disc, vertebra, disc. This disc has come out. It has prolapsed and it will compress the nerve roots. For example, if this is L5 vertebra and this is S1 vertebra, so between the L5 and S1 vertebra, if a disc comes out, it will usually compress the S1 nerve root. But which is the most common compression in human body? L4-5. Compressing the L5 nerve root, the commonest compressed nerve root. When I look at the disc prolapse, also called as sciatica, the clinical presentation is a backache going down to one lower limb. When you examine them, if you ask the patient to lie supine and you raise his one leg and he feels a stretch on the posterior side of thigh, it is called as an SLR or Lasix test. So if the angle between the bed and the limb is more than 70, it's good. Less than that, it means the nerve root is getting stretched. In such a condition, MRI is the investigation of choice. It can pick up the degree of compression, can also calculate the diameters. Usual diameters of the spinal canal, which are adequate for the nerve roots, are 10 millimeters. Beneath that, an intervention is usually required. Lumbar disc prolapse is more common than cervical because the lumbar disc has less water content. Most common level, L4-5 more than L5-S1. Lower nerve root is compressed, that is L5 level. Some important myotomes. C5, shoulder abduction, elbow flexion. C6, wrist extension. C7, elbow extension. C8, finger flexion. T1, intrinsic muscle of hand. And coming to sensory supply, remember the trident hand? C6, thumb. C7, index and middle finger. C8, ring and little finger. In hand, C5 and T1 do not have sensory supply. Myotomes, L2, hip flexion. L3, quadriceps, knee extension. L4, ankle dorsiflexion. L5, extensors of the great toe. Extensalis longus. Commonest compressed nerve root. Important for you to remember. S1, flexalis longus. Dermatome, sensory supply of lower limb. L4, medial part of leg and foot. L5, lateral aspect of leg, dorsum of foot and great toe all around. S1, sole and little toe all around. So if I look at this, L4, medial part of leg and foot. L5, lateral part of leg, dorsum of foot and great toe all around. And S1, sole and the fifth toe. Which is the most important? L5. Because L4, L5 is the commonest disc prolapse. If a patient has these signs, it means be aggressive. Bowel bladder involvement, history of malignancy, no improvement in site of rest or worsening, steroid more than 4 weeks. These are red flag signs, intervention required. Yellow flag signs, mood disorders, insignificant clinical features, psychosocial factors, yellow dirty fellow, to be ignored in backache. Treatment of disc prolapse. We'll remember plan A, We did this in compression neuropathies. Many inflammatory disorders. Plan A. Plan A is a name we have given. It means rest plus NSAIDs, if not released, if not relieved, local steroids, not oral, local steroids, injectable. If not relieved, surgery. In case of disc prolapse, you will make a hole in the lamina, remove the whole of lamina or remove half lamina, called as laminotomy, whole, laminectomy, removal complete lamina, hemilaminectomy, removal of half lamina. So this is what the feature is: making a hole, removing the disc, or opening the entire lamina or the half lamina. If there's a narrow lumbar canal diameter, less than 10 millimeter, patient will have claudication. As he will get up and walk, he will feel heaviness. As he will sit down, he will be better. This is treated with removal of complete lamina or opening a window and hinging on the back, creating more space for the neural canal, the nerve roots and the spinal cord, called as laminectomy or laminoplasty. Hoover's sign is a clinical sign to discover malingering in a patient. Another test for malingering is Worrell's test. Remember these two names, it should be good enough for you to crack questions. When I look at oblique or lateral view of spine, I see a dog. The ear of the dog is made by superior articular process. The front leg of the dog is made by inferior articular process. And the neck of the dog is made by an area called as interarticularis. Whenever I run, I jump, I turn, I fall. All the forces of my spine, they go to this area of interarticularis, and this is the weak link. Whenever a vertebra breaks, it breaks from this area. This is called as spondylo, means vertebra. Lysis means break. Spondylolysis, there is a break in the neck of the dog or dog with a collar in the neck. When the neck breaks, the head falls. So, when there is a slipping of one vertebra over the other, it is called as spondylolisthesis. Most common level where spondylolysis occurs, L5. Listhesis occurs between L5 and S1. When this breaks down and the head falls, it is called as beheaded Scottish Terrier sign or beheaded dog sign. So L5 spondylolysis, L5S1 spondylolisthesis, L4L5 disc prolapse. Remember. And when one vertebra completely slips over the other, overlapping vertebrae make an inverted Napoleon hat sign seen in end stage of spondylolisthesis. Let's look at some disorders which affect the tissues or the damage. If there is a ball that comes to somebody's hand, takes his thumb completely radial, it can damage the ulnar collateral ligament of the first metacarpopharyngeal joint. This situation is called as gamekeeper's thumb. There is a torn ulnar collateral ligament of the first metacarpopharyngeal joint. It is the most common injury of MCP. It is treated by cast application. Sometimes, in between the torn ulnar collateral ligament, the adductor pollicis muscle can be entrapped. This is called as Stener's lesion, and this is an indication for operative management. Usually, it is the phalangeal insertion which is avulsed at the metacarpopharyngeal joint. If there are inflammatory conditions, the muscles or the ligaments on the insertion of the bone are inflamed. An example, tennis elbow. The lateral epicondylitis, common extensor origin, is inflamed at its insertion, and when you resist the wrist dorsiflexion, there is pain on the lateral epicondyle called as Cosine test. Most commonly involves the extensor carpal brevis, then the longus. Tennis elbow. Plan A is the treatment. Or golfer's elbow, the medial epicondylitis. The student's elbow, olecranon bursitis or decurvens tenosynovitis. If I look at my thumb, the first extensor tendon compartment tendons, abductor pollicis longus, extensor pollicis brevis, if they are inflamed, you put your thumb inside, make a fist, take it towards the ulnar side. You will feel a stretch over the tendons of the first extensor compartment called as abductor pollicis longus, extensor pollicis brevis. This is severely painful to the patient, called as Finkelstein test, and his disease is decurvens tenosynovitis. Treatment is Plan A. Or you can have a housemaid's knee. Prepatellar bursitis is housemaid's knee. Treatment Plan A. Or you can have infrapatellar bursitis, the clergyman's knee. Treatment Plan A. Or you can have inflammation among the first MTP, head of first metatarsal bunion, or the base of fifth metatarsal, the bunionate. So these are the inflammatory conditions. All are treated by Plan A. Decurvens involves abductor pollicis longus and extensor pollicis brevis. Finkelstein test, Plan A. Or you can have insertional tendonitis of tendoachelis along with retrocalcaneal bursitis called as Haglund's deformity. Or when there are diabetic alcoholic patient on anti-epileptic therapy, they are patients of renal diseases, or tubercular patients or pulmonary infections. Their palmar aponeurosis can undergo permanent contractures and it can be flexion of MCP, interphalangeal joints. If you look at the lateral view, in claw hand there is hyperextension of MCP, flexion of interphalangeal joint. Claw hand occurs because of the absence of lumbricals, but here because of palmar aponeurosis contracture, the MCP, interphalangeal joints, they flex. Dupuytren's contracture involves the ring finger more than the little finger. MCP followed by PIP followed by DIP. Treatment is wait and watch. But if the patient has more than 30-degree deformity at MCP or more than 15 at PIP, you will do a surgery, subtotal fasciectomy. This is a disease in which collagenase has also been used. Dupuytren's and gamekeepers, they keep on coming alternate years. One of the commonest MCQ world is rocked by this question. Avulsion of extensor tendon from the distal phalanx is mallet finger. It can be soft tissue, it can be bony avulsion. Treatment is application of a splint for a period of 6 to 8 weeks. It usually has good results. Opposite of it, avulsion of flexor tendon from the distal phalanx is jersey finger. FDP is a worst hair, and the treatment is surgical. Mallet finger conservative, jersey finger operative. Bowler's thumb. Bowling is a craze. When you hold a bowl with a groove, the thumb in the groove, just around the ulnar border of the thumb, there can be fibrosis of the ulnar little nerve of thumb. This is bowler's thumb. Treatment, Plan A. And then the lateral deviation of the great toe is called as hallux valgus. It's a spot diagnosis. Rotator cuff muscles, the supraspinatus, infraspinatus, teres minor, and subscapularis. They have 3 diseases which have same treatment principle. The tear, chronic inflammation, not allowing the movements to occur called as impingement syndrome, or subacute inflammation where movement between 60 to 120 is limited called as painful arc syndrome. All 3 conditions They are treated by plan A. The only difference is in plan A you give rest and NSAIDs. Here, because joint movement is important for life, you give physiotherapy and NSAIDs. If not relief, local injection of steroids. If not, surgery. Frozen shoulder, also called as adhesive capsulitis, is usually seen in cardiac patients or diabetic patients. They have decreased abduction and interrotation in the patient, and treatment is plan A. They have classically night pain. So shoulder, night pain, loss of movement, frozen shoulder. So diabetic patient, night pain, frozen shoulder. Diabetic alcoholic, hand deformity, Dupuytren's. 60 to 120 is the painful arc. When I look at the fragmentation of the cartilage in a joint along with underlying bone, it's called as an osteochondritis. Osteochondritis dissecans is the collapse of the cartilage along with the bone on the lateral surface of the medial femoral condyle. This is seen in adolescent. And osteochondritis dissecans, there is a Wilson test which is done for it. The underlying bone is exposed. You can make multiple holes in it, which will regenerate a cartilage, called as microfracture technique. The other varieties of osteochondritis, Kienbock, is osteochondritis of lunate. Both have N in between. Koehler, navicular. Freiberg, second metatarsal head. Isolene, fifth metatarsal based. Sievers, calcaneum. All these are osteochondritis, very common in second decade of life. So in osteochondritis, it's basically identification of which bone in which osteochondritis. Kienbock, lunate. As we all know, the lower end of radius, the big bone that sleeps over it, the scaphoid, and just next to it is the lunate. Or you can have the navicular, lur, Koehler, lur, they have the same ending. Or osteochondritis involving the vertebrae, Sherman's disease. A, vascular necrosis, death of a bone due to poor blood supply. Common sites, the head of the femur, the proximal pole of scaphoid, the body of talus, or the proximal pole of lunate. Along with that, there can be avascular necrosis involving the head of humerus, the capitulum, the distal femoral condyles. These are 7 areas. The avascular necrosis of the head is related to the main blood supply being damaged, the profunda femoris, or the medial circumflex femoral artery, or its branches, the lateral epiphyseal arteries. The blood supply goes from distal to proximal. That is why the proximal area undergoes avascular necrosis. Dead bone appears white. That's why the dead bone appears white. Similarly, in scaphoid, it is the blood supply coming from distal to proximal. So the proximal area undergoes avascular necrosis. That's how it looks like, white. In the head of humerus, it appears there is a cap of snow called as a snow cap sign seen in avascular necrosis of the head of humerus. The most common AVN involves the head of femur. It involves the anterolateral aspect of the head, and in different positions of the hip, the rotations of the hip are changing, called as sectoral sign. When you look at the X-ray in this area, you will see a crescent reclusancy called as a crescent sign, which is a feature of avascular necrosis of upper end of femur. There can be 2 thick bands on MRI, classical MRI double sign. The pressure inside the bone is high. Go inside till the head, make some holes, release the pressure, called as core decompression, going till the core of the head of femur. Or you can take a blood supply along with the muscle, insert in the head, called as muscle pedicle graft. One example is a quadratus femoris graft, in which you put quadratus femoris in the head, called as Mayer's graft, or classical surgery in today's world, hip replacement. Number 1 for avascular necrosis. Ganglion is the most common swelling of hand and wrist. It's a cystic structure, not lined by a synovial fluid, mainly in the dorsal of the wrist. Pops out. The synovial fluid along with the area will pop out in between the scapholunate. Treatment: rest, no relief, local steroid, no relief, excision. Plan A. Similarly, a cystic swelling around the knee between the semimembranosus and the medial head of gastrocnemius is called as a Baker's cyst. Occurs due to high pressure situation in the knee. Can be because of osteoarthritis, rheumatoid arthritis, medial meniscus injury, or a pigmented villonodular synovitis. Usually they are asymptomatic, can be excised if symptomatic. They become more prominent on extension and on flexion. As the knee capacity increases, they disappear.